Hello everyone, and welcome to American Thought Leaders Now, our special news-focused spin-off series of the original American Thought Leaders program. Today, our very special guest is Dr. Harvey Risch, Professor Emeritus of Yale University. Dr. Risch, so good to have you back.
Pleasure to be with you.
A lot of people know of your work early in the pandemic around hydroxychloroquine. It's amazing, actually, that a lot of people don't know that you are actually, your professional work has been in the realm of cancer. And there's been a lot of discussion. There's been the rise in what have been dubbed turbo cancers. And so what is the reality of this situation right now?
Well, the reality is that there's indications that cancers are occurring in excess in people post-vaccination. Now, do we have proof of that? Not really, but there's data and observations that are consistent with that. So, for example, try to get a clinic appointment in an oncology clinic in a major metropolitan area in the United States, you find that the appointments are backed up, that it could be months rather than weeks to get an appointment. I've heard this from a few places. The idea that a new product like the vaccines could cause cancer is not something that's going to be observable overnight. That cancer as a disease takes a long time to manifest itself from when it starts, from the first cells that go haywire until they grow to be large enough to be diagnosed or to be symptomatic, can take anywhere from 2 or 3 years for the blood cancers like leukemias and lymphomas, to 5 years for lung cancer, to 20 years for bladder cancer, or 30, 35 years for colon cancer, and so on. So these are long-term events, and if you suddenly introduce a new product like the vaccines, the first thing you might expect to see would be the blood cancers that I mentioned, but not the other kinds of cancers. And so what clinicians have been seeing, however, is very strange things. For example, 25-year-olds with colon cancer who don't have family histories of the disease. That's basically impossible along the known paradigm for how colon cancer works. And other long latency cancers that they're seeing in very young people. This is just not the normal occurrence of how cancer works, and so there has to be some initiating stimulus to why this happens. In my opinion, cancer is something that the body normally fights off because the cells that get created when they go haywire, the immune system mostly recognizes and manages to gobble them up or disable them so that they don't progress. But if you damage the immune system in a way that limits the ability to recognize or to disable newly growing deranged cancer cells, then that opens the door to them multiplying to the point where it's beyond the immune system to cope. And that's the mechanism, I think, that's the most likely here. That we know that the vaccines, the COVID vaccines, have done various degrees of damage to the immune system in a fraction of people who've taken them. And that damage could be anywhere from getting COVID more often, getting other infectious diseases, and perhaps it may also be cancer in the longer term. So we're seeing these long latency cancers. We're also seeing cancers like breast cancer. So breast cancer typically is a disease when a woman has a detected lesion, a spot in the breast, and that's removed or biopsied. And then it's treated and it goes into remission and sits around quiescent in the body for 20 or 25 years before it may recur. And then what we're seeing is, however, vaccinated women who are suddenly, in relatively short periods of time, re-manifesting their quiescent breast cancers. That's in the realm of possible, just like the blood cancers could be in the time frame of 2 or 3 years after the vaccines. So those are the initial signals that we've been seeing, and because these cancers have been occurring in people who are too young to get them, basically, compared to the normal way it works, they've been designated as turbo cancers. Some of these cancers are so aggressive that between the time that they're first seen and when they come back for treatment after a few weeks, they've grown dramatically compared to what oncologists would have expected for the way cancer normally progresses. And so that's part of the motivation for calling them turbo cancers. We don't know how big this problem is. It's certainly not universal, but is it a real problem? Potentially, yes. And so one needs to be just cognizant of it and paying attention to it. And as the American Cancer Society has said for so long, be attuned to your body. that any changes that don't make sense to you in your body, follow them up. That's the best recommendation.
So there isn't population level surveillance on this? Because you would imagine that there probably is very good population level surveillance on this.
The problem is connecting the cancer occurrence to the vaccinated state. That the population surveillance for cancer is good because cancer is a reportable disease. It's 1933 in Connecticut anyway. But knowing which people have been vaccinated and when they were vaccinated compared to the cancers is very weak data if it exists at all. So there might be reports in the VAERS database about cancers, but again, if this is happening 2 years after vaccination, how are you going to lay the claim that this was caused by something 2 years in the past? It's difficult to make those connections.
Fascinating. Well, the other issue is, you mentioned breast cancer, coming back, that was treated in some way at some point. But there was also this whole phenomenon early in the pandemic that a lot of this kind of surveillance type work, or just assessing mammograms, that kind of stuff, was simply not done, right? Because the hospitals were locked down, right? And so how much would that play into the turbo cancer question?
I think that it's unlikely to affect the turbo cancer question. It's more likely to affect a bump in cancer diagnoses after the lockdowns were lifted and people were more psychologically prepared to go back into public spaces and clinics and make their appointments and attend their appointments. So there would have been a bump, a wave in that period, but not long stretching into now, years later. I think that, and the behaviors of the cancers, as I said, they're more aggressive, is something that would be unexpected and not related to that.
I just want to talk about this, the data on whether someone's been vaccinated. There was, from what I understood at one point, there's kind of a range of how whether someone's been vaccinated was defined, and it was anywhere between 0 to 3 weeks after the actual shot was given that they would be marked as vaccinated. I think 2 is kind of the most common number that I hear, 2 weeks. And presumably we have data on who has actually gotten the shot. Right?
Well, not really.
Okay.
So if you go to hospital for some procedure and the hospital looks up your medical record to see if you've been vaccinated, the data in the chart will be, there's a checkbox for vaccinated and a checkbox for unknown. And the reason it says unknown is because the hospital only captures the fact of vaccination for people who got their vaccines in the hospital or in a clinic that's related to the medical care system of the hospital. And there may be information elsewhere in the chart, like in a text box somewhere that says patient received vaccines at such and such date, but it probably or may not populate into the box information about vaccine status. So it's murky, it can be murky. As to the question of when is a person vaccinated, this is one of the great misrepresentations of COVID, and that is when you're studying the efficacy of an agent, if it takes a few days to weeks before an agent becomes fully effective, then it's fair when you're looking at the effectiveness of the agent to say, okay, so we'll not count you as vaccinated for 2 weeks until the vaccine ramps up its ability to be a vaccine. Fair enough. But at the same time, you cannot use that for harm. That there have been many government CDC analyses of vaccine adverse events, and they put people who've been vaccinated but haven't gotten to 14 days into the unvaccinated camp, using the same reasoning that it hasn't had a time for the vaccine to become effective. But the hazard happens as soon as you've been randomized. Before when you get into your car to go get the vaccine, you're already in the vaccine group for any adverse events. And so that's been a major misrepresentation, because serious adverse events of the vaccines have largely been within the first 4 days after vaccination. And so if the first 14 don't count for being a vaccinated person, then that's putting approximately 3/4 of those adverse events into the unvaccinated group in people who've been vaccinated. And so that really misrepresents the data as to objective evaluation of safety. So safety and efficacy have to be done totally different based on different reasoning.
Well, I mean, this is, of course, might be for those that are unfamiliar with this reality, absolutely astonishing, right? That such a designation would be made, because it kind of looks like people are trying to hide the harm, right? I mean,
well, I agree with you.
Yeah.
But I think there's been so much misrepresentation, you know, in what public health has done over the last 3 years, that it threw out the principles of public health 6 days into the pandemic and did the opposite of everything that we knew should be done for respiratory viruses. You know, the fact that public health has been so bad and led to so many bad outcomes for so many people, both dying from COVID and dying from the vaccines and serious adverse events from both, because of restricted access to effective early treatment, unnecessary vaccination in people who didn't need it or would have increased risks because they'd had COVID in the past and didn't need, and the vaccines would just increase their risks of adverse events and so on. There's been a whole pile of major misrepresentations through the COVID period by public health that has been a colossal failure of public health through this period.
You know, to your point, we, my wife and I made the film The Unseen Crisis, looking at how people that have been injured, documented to have been injured by the vaccines, are often, you know, doctors don't even know what they're looking at because they haven't heard that it's a thing, for starters. And then in some cases, you know, being marked as, you know, some sort of functional disorder, hysteria, and then, you know, once you have that in your chart, it's very difficult for anyone to take you seriously. This is what we've learned through our research. This whole...
That's called medical gaslighting, by the way. That assigning a mental cause to something that says this person is psychologically imbalanced, and that's what we're seeing, rather than an actual functional cause because the doctor didn't know enough and didn't look thoroughly enough to see what was going on and didn't do the right tests, is medical gaslighting, in my opinion.
Is there any way to disambiguate this data? And that's my first question. The second one is, what studies can we do to understand, well, let's start with this turbocancers phenomenon, and then the broader question of harms related to genetic vaccines?
I think it's going to be difficult. Let me do the second question first. That what we know about vaccines being attributable to the cause of death comes largely from autopsy studies where you can prove that the vaccine spike protein was in the organs damaged enough to have caused the demise of the vaccinated person. And that was the Hulscher paper that we've been trying to get published, that's on Zenodo, I think, at the moment, with Dr. McCullough, that showed that 74% of the cases that they were able to attribute to vaccination as a cause of death. So those autopsy studies provide the data to implicate the spike protein in the damaged organs. That's the link that's necessary. In a turbocancer, you might not see that because the spike protein might not be in the cancer driving the cancer. The spike protein came and did its damage and left, and the immune system failed, and now the cancer has been growing and became so deranged that it's very aggressive. And, you know, it's like it did its damage and went off somewhere else, and so you don't see the telltale trace of the spike protein in the cancer, and so it's very hard to attribute. So I think that's going to be a much harder question to study.
Fascinating. Well, and then to go back to the sort of original question, so with the data that exists today, is it possible to, at what level is it possible, or would the effect need to be just so strong of that you know, the vaccine being connected with the incidence of, say, the cancer or other harm?
I think the only way that we'll deal with this has been in the classic epidemiologic methodology, which is to do case control studies where you have, say we look at colon cancer. So you do a study, you sample, try to get everybody in your state who's had colon cancer over some period of time, and say you collect 2,000 people with colon cancer. And you get to them as soon as possible and you interview them about their risk factors. And among that, you ask them about whether they were vaccinated and how many times and when. And then you get a representative sample of people in the same state, the same population, same age range, same genders, distribution, and so on, and ask them the same questions. And you look for differences in the vaccination status between the cases and the controls, and you adjust for all of the known risk factors for colon cancer, because if there's any differences between the cases and controls, those could account for the cancer state, and so you have to account for them and control for them. And that's what we do day in, day out in our our epidemiologic studies, and we know to do that because over the last 40 or 50 years we've learned a lot about the diseases that we study, and so we know what the major risk factors are, and so we know that we have to measure them and that we have to control for them. And that's the reason why these kinds of studies are just as powerful and objective as randomized trials, if not more so in some cases, as randomized trials for looking at the same kinds of relationships. Because we're not just fetching in the dark these kinds of cancers in 1985. We've learned a lot in the intervening years, and so we know how to adjust them to make the studies objective and not biased. And so those are the kinds of studies I think we'll have to do.
You know, something that just struck me, if you did a large enough sample size of a study that you just described, you could actually be able to tell to some extent the effect of what would happen if you only categorized someone as being vaccinated 2 weeks in or something like this.
Correct.
Right?
Yes.
Yeah.
If people could report on that accurately, yes.
Fascinating. So I guess what I'm saying is that there are studies to be done that the NIH could be running right now.
What's interesting is in my opinion, having gotten all these kinds of studies funded over my academic career, that there's a lot of bias as to what gets approved for research in NIH and investigator submitted kind of grant applications. And you have to make them attractive either by having some very novel and non-political hypothesis to be addressed that nobody has ever studied in the past, so there's a reason to collect the samples. And it can't be the second study of anything. No second study of anything ever gets funded because it's not novel. There's the novelty fetish. And it can't be something that radically contradicts prevailing ideas in the epidemiologic and medical community, because then they'll say, well, this is obviously not true according to such and such, and why would we want to spend $5 million? And these studies are expensive. A typical study like this would cost $5 or $10 million to do. So and take 5 years or 7 years or whatever. So it's not simple and it's not easy. Can be done, takes a lot of work and some good luck on basically the way this would be done is by camouflaging the politically charged elements of the study in with something else about why it's interesting to do another case control study of colon cancer, say, that there has to be a novelty factor in that. If you can get that in and get it funded on that basis, everybody adds questions to their questionnaire, you know, that you didn't think of at the time you proposed the study. And to do that is not fraud, it's just science evolves and normal to do. And I'm not advocating that people misrepresent what they're studying, but they have to some degree, play the system that's already out there to be effective in actually getting progressive, interesting science done.
Very interesting. I hope a lot of scientists are watching this episode.
It's not going to be solved overnight, even if studies get funded. This will be more difficult to do.
I want to switch gears. There's been rumblings of mandates of various types of, you know, let's call it guidance. That's what everybody's saying it was these days, right? Around restricting viral spread with some of these new variants that are coming out. What's your reaction to that?
In what way did any of those recommendations restrict the spread of the previous variants that came out? The answer is none of them did. So it's fallacious thinking, and the definition of insanity is when things don't work, just doing the same thing over again, knowing that they didn't work the first time. I think that's where our society is at. Doubling down on the wrong things is even more destructive than it was the first time. But I think a lot of the population is fed up with all of that, is taking COVID in stride, is not going to be propagandized into thinking that a virus substrain like BA 2.86 that now has, what, 8 cases, 10 cases worldwide, is something that's going to calamitously take over the world in the next month. That's not going to happen. And all of this is propaganda to sell the next batch of vaccines coming out in a few weeks. So people know that. They instinctively know that already. They're fed up with this. And they're not going to stand for it. And there's going to be a lot more pushback on all this stuff, I think. And we've been through these cycles. We were naive the first time we went through this as a society. We're not naive now. And that puts them in a very different position of succumbing to things that they didn't want to do the first time, but did because they didn't know. Now they don't want to do them, and they know that they're not beneficial and they don't work.
The safety profile or the safety of these vaccines is, I think it would be fair to say, oversold. Okay. What about these?
And the efficacy has also been oversold.
What about the safety and efficacy of these new ones?
We have no information whatsoever. They haven't been tested against really anything in humans in an objective way. The first ones were not tested objectively anyway, that the safety component was terminated a month after the study ended, so there was no real follow-up. The number of outcome events in the clinical trials was way too small to make the randomization useful. So there was no way to, and when one looks at all-cause mortality in the, for example, the Pfizer trial, you see that it's comparable. There was 19 in the placebo group and 20 in the drug group or the vaccine group or something like that. So that's telling you, even though those numbers are very small, it's not telling you one's bigger than the other because the numbers are too small. But it's telling you there's no obvious signal here that the vaccines are reducing mortality. And there should have been. And so we're stuck with improper and inadequate testing that passes for proper testing, that the FDA, wink, wink, approves these things. And now the latest rationale is antibody levels. And everybody knows, scientists know, that antibody levels don't correlate with immunity. That antibody levels rise after you're exposed to an infection, and so does immunity. And is it the antibody levels? No, it's the presence of antibodies that matters, at least for a while. And then T cells take over, and they matter. And antibodies can last for various periods of time, and same with T cells. But people stay immune. They lose their immunity gradually for some diseases. This is all how the immune system works. You can't measure it, you know, with antibody levels 2 weeks or 3 weeks later. That is not telling you anything about how immune the individual is. And so we don't really know about the efficacy of these vaccines, but we do know that they're following the same production as the mRNA, the mod RNA vaccines from all of the first batches, the first go-rounds. And so there's no reason to expect anything different from these. And that's a big hazard because the hazards from the first ones were serious enough that as a society we were damaged by them. My estimate now for serious adverse reactions to the vaccines is about 1 in 140 people will have a serious adverse reaction. Now, 1 in 140 says to me, if I were going to choose to be vaccinated, that's so low, it's unlikely to affect me, so I would consider to do it. But if you vaccinate 300 million Americans, 1 in 140 is still hundreds of thousands of people, right? And that's not tolerable for a society where hundreds of thousands of people are not going to be seriously affected or die from what you're trying to prevent, the COVID infection, especially now in the Omicron era. So the trade-off for a society is wrong even if an individual on the same probabilities might choose to take the vaccines. And the blurring of that distinction is another one of the frauds in public health that we've been through. That saying safe and effective because you only have a 1 in 140 chance of being harmed sounds good to an individual, but it's terrible for the society.
So for the typical person that would be asking themselves, you know, with these variants and this kind of vaccine, what we know, what you just described, what should they be thinking?
Well, my opinion is that nobody should be vaccinated against this anymore with any of these mRNA vaccines. And it remains to be seen what's going to happen going further, but my guess is that the variants that continue to circulate will still be Omicron-like, low level. I've heard of a few people being hospitalized from the current variants. The hospitalizations have been for a few days. Nobody's been really seriously ill. It hasn't been life-threatening. It's been unpleasant, and most people basically have had colds with it. Most people have already had COVID, so they already have some degree of immunity, even to these new subvariants. So there's no reason for people to be vaccinated now to any degree. Even people with chronic conditions, they've already been through vaccination and or being infected. So it's very rare that people like that even would benefit from the new vaccines.
A final thought as we finish, Dr. Risch?
We thought we were done with COVID in June of this year. The whole country wanted to be done with COVID in June of this year. We've been saying that we were done in January of last year when Omicron was already upon us and we knew that it was a flu-like illness and no longer an emergency. But nevertheless, the whole society recognized it was time to move on from dealing with this as an emergency and more as just one of the infection at noon problems of modern society, that we live in social contact with each other and therefore spread low-level infections. This is part of human life that we take for granted and try to treat the best we can. And that's how we should be managing this, and not being forced to freak out by propaganda that all it's doing is the tentacles of the government working as the PR arm of pharma to sell more vaccines.
Well, Dr. Harvey Risch, it's such a pleasure to have you on again.
Thank you. Great to be with you.